This video is about the drug kit itself. This is Mike McCracken. I'm teaching with Dr. Guy Rosenstiel and Dr. Anthony Caputo at the Foundry Dental Center. We're going to focus on what is in the emergency drug kit. It's one on top of Rolling Thunder here. You'll find that in the clinic. And we discussed this briefly in the introductory video. So you see the different medications that are available here. We're going to start with the reversal agents, flumazenil and naloxone. So flumazenil is probably one of the drugs that I think about soonest if I'm having a patient in respiratory distress or somebody that's not breathing as much as you want to. Flumazenil is definitely one of your go-to drugs. It's wonderful to have the ability to reverse the benzodiazepines, get somebody so that they're breathing better in the event that they go into a deep sedation when you're really shooting for moderate sedation. So flumazenil is a competitor for the receptors that are activated by midazolam and other benzodiazepines. Typically we're using midazolam, but you could be using something else. Flumazenil will bring them back up in their level of consciousness if they're too deep. You can do a partial reversal if you wish. You can give them a 0.2 milligrams over 15 seconds, and maybe somebody that's been in a deep level of sedation inadvertently comes back to a moderate plane, and that's convenient. It takes about 30 seconds for the drug to take effect, and so as you're working with them, give them 0.2 milligrams, wait 20 or 30 seconds. Give them 0.2 milligrams, wait 20 or 30 seconds. And most everybody that I've seen responds to about 2 doses. What I read in the literature, it can take up to 1 milligram, which would be 5 doses over a period of a few minutes. But this will bring the patient back up in their level of consciousness. If you're not getting that, then I would look for things that are depressing the consciousness other than benzodiazepines. It's important if you use flumazenil to remember the half-life is shorter than most of the benzodiazepines out there. So if, for example, your midazolam has a clinical effect of 30 minutes and your flumazenil has a clinical effect of 20 minutes, the flumazenil will wear off and the patient can potentially resedate. Said another way, you're using a long-acting benzodiazepine, you bring them back up to moderate level or to an alert level of consciousness, but then at 30 minutes, the flumazenil wears off, benzodiazepine is still on board, and they resedate, but now unfortunately they left your office. So if you give flumazenil, it's important to wait at least 20 minutes for the flumazenil to leave their system. So after 20 minutes, the average patient, you're not looking at the flumazenil any longer, and you can evaluate their level of consciousness. In some studies, the flumazenil effect in some patients goes out 45 or 50 minutes. So if you want to be super safe, wait 45 minutes after your last dose of flumazenil. Make sure the patient is alert and conscious and ready to be discharged. They say the maximum dose for this is 3 milligrams over the course of an hour. If you're not getting an effect at 3 milligrams, so that would be dosing them at 20 minutes and then dosing them another milligram 20 minutes later, and at 60 minutes dosing them a third milligram. That's going to cover your benzodiazepines. It's an aggressive competitor at those receptor sites. Naloxone is the reversal agent for opiates. It is an opiate antagonist, and it will outcompete the opiates on board to occupy the receptors and will reverse the effects, particularly the lack of breathing effects and the sedation effects. Unfortunately, this can also trigger withdrawal symptoms. So in our clinic, where we have a lot of addicts that are recovering or maybe even currently struggling with drug addiction, we're reluctant or slow to reverse the opioids, fearing that we might trigger a big reaction. So they get sick, they vomit, they get mad, they get violent. And so if we give this, we give it slowly and titrate it to effect. When we've used it, is not often been in the sedation arena, but rather in the waiting room or in the parking lot Those paramedics would know this as well. You have a lot of people that are overdosing and need naloxone to recover respiratory drive. This drug is supplied in 0.4 milligrams per ml. You can give it in a variety of ways: IV, IM, nasally, subcutaneous. So it's easy to administer. You've got an IV set already, most likely. That's the fastest route. So you get 0.4 milligrams, that's 1 ml in this formulation, every 2 to 3 minutes. And again, I would give it, I would wait for 2 to 3 minutes, I would give it again and titrate in that way so that you don't do a hard cold reversal on somebody that's used to opioids in their system. Atropine is used to treat bradycardia. Symptomatic bradycardia is an anticholinergic. It sort of opposes the action of the vagus nerve. It counters the rest and digest systems, parasympathetic systems, and also reduces secretions. So some people will use this for bronchial secretions prior to intubation, and in the past it's been used to reduce saliva and help with dental impressions. I don't know anybody personally who actually does that. It would dry up the mouth. It's supplied in 0.4 milligram per ml concentration, which is awkward because you're not supposed to give less than 0.5 milligrams due to a reaction where the patient can actually have worse bradycardia. So the recommended dose is 0.5 milligrams or 0.5 to 1 milligram IV every 3 minutes. And so that would be 2 mLs if you were using this dilution at 0.4 milligrams per ml. It's more than 1 ml is my point. Don't give them 1 ml. That would be 0.4. A similar medication is glycopyrrolate. It is also used to dry up secretions. Anesthesiologists tell me it's a quote, cleaner drug than atropine, so you could use it for bradycardia, but it's got expensive. It used to be, I don't know, $7 or $8, and now it's $100. So I don't use it. I use the atropine if I need it. The anesthesiologists do sometimes use this for intubation, and I always notice, but of course I don't say anything. In addition to raising heart rate with your atropine, you may have a need to increase blood pressure with one of the pressors that we keep in the clinic. So these increase mean arterial pressure primarily through vasoconstriction of some vessels with alpha effects, also through increased cardiac output with beta effects. The pressors that we have on hand are epinephrine, phenylephrine, and ephedrine. The ephedrine we keep in the safe because it's a Schedule IV medication. Epinephrine is used in a variety of medical emergencies, many of them in the ACLS protocols. You can use it for anaphylaxis. If you had a bronchospasm or an asthma attack that didn't respond to albuterol, for example, then you might give some epinephrine in those situations. It affects most of the organs. It's a powerful drug, so we wouldn't use it typically just for increasing blood pressure, but it is good to talk about because it explains the mechanism and sort of puts everything into perspective. So if you go back to your dental school lecture, somebody talked to you about fight or flight, that somebody's hiking and you walk around the corner and all of a sudden you're looking at a bear. Your body dumps epinephrine into your bloodstream, and this allows you to survive. You have an opportunity to fight the adversary or flee. And so depending on what's needed in different organs to help you survive, the epinephrine has a variety of effects, and sometimes they're almost divergent in some ways, but they all do get back to this fight or flight situation. So for example, you don't need blood in your skin, you need it in your big muscles to run. So you need it in your legs, you need it in your skeletal muscles. So you have vasoconstriction in the skin. You don't need to be digesting food in an emergency bear situation. So you'll divert that blood again to the skeletal muscles. Your heart rate will increase so you can run. Your lungs will dilate so that you can, your bronchioles will dilate so that you can breathe better. Your pupils will dilate so you can get more light in. You can see more. You can fight and run and these pressors have similar effects as epinephrine does. If we look at the receptors briefly, or the effects of epinephrine, you have different receptors, different organs, different parts of the body. So the alpha 1 is our primary vasoconstriction effect that increases the blood pressure in our patient. So you find this in the skin. The kidneys, you want to retain urine for the fight or flight, so those constrict. The pupils dilate, and you have an effect on the liver by increasing glucose in the blood system. Alpha 2 is a smaller number of receptors. These have a central action in the brain to lower vascular constriction in some other vessels where you might need more blood, for example. I bring it up here because we have patients that will take clonidine. I don't know what it is about our clinic, but they'll take clonidine to relax themselves, but this also lowers their blood pressure, and we see this sometimes when we sedate them. So alpha 2 agonist like clonidine or like dexmedetomidine do have a sedative effect, as well as the vasodilation, lowering of the blood pressure. Beta 1 effect is primarily associated with the heart. Increased heart rate, increased contractility, increased conduction, all give you more cardiac output and increase your blood pressure. Beta 2 are associated with the lung, the receptors associated with the lungs. This causes bronchodilation and vasodilation in some other tissues. The dose for anaphylaxis of epinephrine is 0.3 milligrams. You can see in the picture on the right, this concentration is 1 milligram per ml. This is really made for IM use. You have opportunity for these in the ACLS protocols. Every pulseless individual, or EPI or EPI, gets a milligram in those protocols, and you would use the, typically given this IV, you would use the 1 milligram per 10 ml solution there. But it doesn't really matter. Milligram's a milligram. If you give it IM or give it IV, it's going to have roughly the same effect. A more common pressor for blood pressure, epinephrine's a big hammer, right? You're affecting a lot of organs. So if you're in the clinic to raise blood pressure, you're going to use either ephedrine or phenylephrine. We keep the phenylephrine in the drug kit. We keep the ephedrine in the safe. So this is the one that you have mostly available to you. It's a good pressor, increases blood pressure, has a relatively short effect. Buy it as a decongestant in the store, and is an alpha 1 agonist. So vasoconstriction is primarily the effect we get with it. The solution that we purchase from the store is 10 milligrams per ml. The dose is 100 micrograms. So you have to be really careful with your dilution. What you pick up, you have to dilute it twice to get it to a usable concentration. And we'll talk about that in the appropriate video on dilutions. Ephedrine is a stimulant. It comes in 50 milligrams per ml, and the dose is 10 milligrams. So this is 1/5 of an ml, or you can, of course, dilute it up to 5 cc's and use that in a more accurate manner. But this is also a short-acting medication, short onset, and you can use this, titrate 10 milligrams per minute to effect. Okay, while we're talking receptors, we should discuss beta blockers, which are medications used to decrease blood pressure. These are the meds that end in "all," like propranolol. So you recognize them by that name. They block epinephrine from cardiac cells, or if they're selective, can block beta 1 and beta 2, or just be selective for the heart beta 1 receptors. We keep 2 beta blockers, esmolol and labetalol. Why they are not next to each other in the kit, that's a question for Dr. Guy, but they are on the top shelf. There you go. So the esmolol is the one that we give first. Labetalol that we might give if we needed to follow with something. It lasts a long time. So esmolol, I remember, it's a Brevibloc. It's fast onset, fast out. Maybe it lasts 10 minutes clinically. It's cardioselective. It does have an effect on the heart rate and can decrease heart rate, but its onset is fast. You can give this in a dose of, say, 1 milligram per kilo. And if you wanted to, you could put it in the bag and start an infusion. The medication that lasts longer is the beta blocker labetalol. The effect takes a few minutes to come in at 5 minutes, but it lasts for a couple hours. The heart rate is mostly unchanged, so if you have somebody that's hypertensive and tachycardic, probably would use a Brevibloc. Generally speaking, we would use the Brevibloc in almost all the cases just to see if it has an effect, see if we can get the patient comfortable, and then if we needed to, follow with the labetalol. Some people would say, hey, if you're given a beta blocker that's going to last 2 hours, you should consider transporting that patient and getting a physician to look at him. The dose for labetalol is 20 milligrams. I'm going to clip through the last couple drugs up here on the top row. We've got promethazine. It's an antihistamine. It has some sedative properties. We'll sometimes use it for sedation. It is a black box warning for IV use. It causes extreme damage to the vessels, can lead to necrosis. So we give this IM only just for safety. Antiemetic is its primary use for anti-nausea, and the dose would be 25 milligrams. Its cousin, elsewhere in the box, is Zofran ondansetron, anti-nausea medication, and you should give this 4 milligram bolus over 2 minutes. Toradol is a very potent NSAID pain medication. It has serious kidney effects, which is why we don't use it more. You can give it as an IV dose of 30 milligrams, and you can follow it PO 10 milligrams every 6 hours, 4 times a day. But again, because of the kidney effects, this is not commonly done. This might be used for a patient that had a severe pain from, I'm thinking, suture line opening, but they are a drug addict and you can't give them anything strong enough, very uncomfortable. You can give them this IV or IM Toradol. Diphenhydramine, Benadryl, is an antihistamine that we use for light allergic reactions. Somebody has a little rash come up from a medication. It does have sedative effects. It's commonly used for sedation in our clinic. Dose of 25 to 50 milligrams, depending really on the size of the patient. Nitroglycerin is a vasodilator used to treat symptoms of angina. As the protocols are, everybody knows if it's their first symptom, you don't know if it's angina or their first MI, so you would transport that patient. But if they have a history of angina, they're having an attack, you can give them 2 tablets sublingual and see if it has an effect. You can repeat that, and then if not, then you would call for emergency assistance and suspect a myocardial infarction. Watch for the double down of the vasodilator. So if somebody's using Viagra, Cialis, etc., and then you give them a nitroglycerin tablet, then that's going to cause serious hypotension. We're about done with the middle shelf. We have succinylcholine and procaine. To finish with that, I'll go with procaine first. This is essentially a vasodilator used for intra-arterial injection, and we'll talk about that in our emergency protocols. But should you unfortunately inject a medication into an artery, it'll cause severe pain, and the skin will get white and the extremity in the hand, and you need to do something to restore blood flow as that artery is spasming. A local anesthetic also eases the pain, but primarily we're trying to get something in there to dilate the vessel. So let's look at the succinylcholine. This medication is used to paralyze patients prior to intubation. For us, we would use this for a patient with laryngospasm. So we'll discuss mechanical ways you can break a laryngospasm, but as a last resort, you might have to use a dose of succinylcholine, and we're suggesting 0.5 milligram per kilo, or say 20 to 40 milligrams bolus IV, and that will paralyze everything. So you'll be breathing for that patient, or you'll be bagging that patient for several minutes while they are paralyzed. Okay, we have 2 things in the kit to correct hypoglycemia. We have the glucagon here, which you reconstitute and is rather expensive at close to $200. And down in the bottom drawer, we have the 50% dextrose, which is much cheaper but harder to administer. So the glucagon is a hormone, and it causes the liver to dump glucagon through glycogenolysis to treat hypoglycemia. It does deplete the stores of liver glycogen, and so after the patient recovers, you want to make sure to feed them, get them some orange juice, etc. Dose is 1 milligram IV or IM. The product is supplied in a powder form, and you have to reconstitute it, but they put a little vial of sterile fluid in there as well. So put the fluid into the powder, mix it up, and inject this IV. The 50% dextrose is simply sugar. It's a very thick IV injection. The box comes with 25 grams of dextrose, and that would be a typical adult dose. You have to have a good vein. If this is infiltrating, then this will cause inflammation in the area. And so you want to check your line, make sure it's flowing, have a good line, maybe even get a larger catheter, but inject this over time. Don't push it too fast, and you can expect recovery in about 8 minutes on average. Finally, in the bottom drawer, we have a couple other things. This is your aspirin for your MONA ACLS protocol, sterile water, Benadryl we talked about, tablet form, some devices, ammonia inhalants. Somebody were to faint or need a little stimulation, epinephrine we discussed, but this is the cardiac or IV solution concentration at 1 milligram per 10 ml. Dextrose we discussed, and then the albuterol inhaler. Albuterol is a beta-2 agonist and a bronchodilator. It is given in an inhaled form. People puff it, push on the little device, it puffs and they breathe it into their lungs, and this gives quick relief to asthma and bronchospasm events. The puffs are about 100 micrograms of albuterol. And I believe that about does it for us. Thank you so much for hanging in there. This has been a discussion of the emergency drugs that we keep as part of our Rolling Thunder kit. This course is taught by Dr. Rosenstiel and Dr. Caputo, and I'm available as well as faculty. We are listing this course on McCrackenImplantEducation.com with our implant courses if you'd like to come join and learn more about IV sedation.